All right, in the interest of time, let's go ahead and get started. So good afternoon and welcome everybody to today's session on quality improvement and patient-centered medical home, PCMH, for clinical leaders and their care teams, a system-based approach. My name is Elizabeth Breidenbach. I'm a meeting and event specialist based in the Clinical Affairs Division, and I'm pleased to bring this event along with my division colleagues. Before we get started, I would like to review a few housekeeping announcements. At this moment, I'm going to be turning things over to my colleague Cheryl, who's going to be introducing today's speakers, and she's our fantastic moderator. Cheryl, the floor is yours.
Thank you, Liz. And I can see that we have folks from all over the country. So welcome, everyone. Our focus for today's session, as Liz said, is on quality improvement in patient-centered medical home for clinical leaders and care teams. We're approaching the conversation today from a systems perspective, and we're thrilled to be joined by an esteemed panel of experts who are going to lead the conversation and, very importantly, also respond to your questions and your comments. So begin to get those in the chat box as we move through today's discussion. We're joined today by our esteemed panel. We have Representative Bill Tulloch from the National Committee for Quality Assurance, and we have two representatives joining us today from the Joint Commission. We have Pearl Darling and Joyce Webb, and I'll introduce them respectively when we get to their section in today's presentation. So with that, if you could advance, we're joined again by Bill Tulloch. Bill is NCQA's Director of Large Account Management and has been with NCQA since 1997. And for many of you who have been involved in regional trainings around the country, Bill is very well known and probably one of the most traveled folks that I know around the country in terms of both covering content around patient-centered medical home and working with community health centers. He's been managing the operations of large government contracts, again, the HRSA PCMH program, and promoting medical home concepts in other large health systems as well. Prior to his work at NCQA, he held a variety of education and training positions, including a program jointly offered by NCQA and the Joint Commission. He is a PCMH certified content expert, and in addition to his bachelor's degree, holds a master in economics. And it's so our pleasure to turn the floor over to Mr. Tulloch. Bill?
Thanks so much, Cheryl. As I'm getting tangled up in my headset cord, I apologize. Thrilled to be with you all today. And actually, I should have sent you an updated bio because I'm now a director in our quality solutions group, but everything else is the same. So it's just a move of departments, so no big deal. And I am thrilled to be with you virtually, of course. As Cheryl noted, I am well-traveled across the country for various events. And in fact, in a fun all-employee event recently, I did calculate that I have been to 47 states for NCQA, almost all of them more than once. So we're trying to get those last three. I've been to the other three for other reasons, but trying to get those last three for NCQA purposes in the future. So why don't we go on to the next slide, which I think is just actually my headshot. You can go right on to the next slide after that, thanks. So really what I wanted to talk about today was sort of the quality, idea of a quality improvement program, but also looking at the medical home model that NCQA promotes, but also is more generally, of course, promoted by a lot of different organizations, to look at how it can really impact those qualitative analyses in quality improvement. I've been talking about quality improvement in various formats in various ways for most of my career with NCQA. And I always think that that why question is so important because it really goes to the heart of not sort of what the numbers are doing, but what is happening within your specific health center, within your region, within your area that can really lead to good ideas, both from your staff and from your quality folks and from your patients, if you've got folks on your board, that sort of thing, to be able to figure out what is the best route to actually intervene to improve. And that's really the important thing in quality improvement, of course. And so that's really what I want to focus on are the sort of what are the basics of quality improvement and then how the PCMH model helps you really do those analyses a bit better. So let's go into some background first on our PCMH program. So if you go to the next slide, that'd be great. We actually have 4 what we call recognition programs. In NCQA parlance, recognition basically means that it is a credential that you earn versus an assessment that is always public. So when we look at health plans, for instance, we have accreditation where if for some reason a health plan were to be denied accreditation, that would be publicly reported. Whereas providers or practices that don't meet recognition standards, they of course get their own results back, but no one else publicly knows that. Though, of course, as part of the HRSA program, the agency is told because they did pay for the survey. But that's actually a very rare occurrence. And right now we have 2 clinical programs in diabetes and heart stroke that are actually recognizing individual clinicians. And then we have 2 practice-based programs, one in primary care and one in specialty care. The primary care one, the patient-centered medical home, is by far the largest and is responsible for the bulk of our clinicians and our 14,000 practice sites that are recognized. Let's go to the next slide and just talk a little bit about sort of how we've broken down the model. And these are very general, what we call concept areas that we have our standards in. But what's important in terms of quality improvement is thinking about how looking at each of these aspects can help you understand both how you're currently operating and where improvements can be made. So when we talk about team-based care and practice organization, sort of figuring out how your specific health center or practice is going to be organized. And of course, this is going to vary by the size of the center, the number of staff and providers, et cetera, but also by the types and the skill sets that you have. And so this is something you need to look at over time and may want to adjust. So what is the practice leadership in terms of clinical leadership, quality leadership, things like that? What responsibilities do different members of the care team have, and are those really the kinds of things that are being done most efficiently? And are there ways that we can get folks that may be not doing certain aspects of care right now to be able to either participate or take over those aspects as you're looking at operational flows and things like that. And of course, also making sure that patients, families, and caregivers, you're dealing with different groups of those folks in different settings, understand the way the practice operates, what their expectations are, but also how to use services, how to contact for questions, those kinds of things. Probably the most important concept is really knowing and managing your patients. And this is an area where health centers, I think, do really well, which is about, of course, data collection on basic things like demographics, age, gender, all that kind of thing, but also looking at social determinants of health, those issues of health equity, looking at preferences for things like appointment availability, really understanding not just your patient's medical and behavioral issues, but also what are the life challenges, the social determinants of health, the regional issues that may be impacting them and also impact their ability to manage care. And so those kinds of things are what we're looking at when we're talking about data collection. This area also looks at things like medication reconciliation, so understanding all of the medications that your patients are on, whether they're prescribed through your practice or through other providers. It also feeds into the kinds of evidence-based clinical decision support you're going to have at your practice. That is, what areas are most common in terms of clinical issues with your patient population, and are there ways you can integrate clinical practice guidelines into the care delivery system rather than relying on folks to either remember the clinical practice guidelines or having to refer to fairly dense and complex publications. And then also that key connection with community resources, another area that health centers really tend to excel in, but looking at things like language issues, childcare issues, transportation, legal issues, all those kinds of things, which may be vital for helping your patients not just be able to sort of navigate the world, but also be able to relieve some of the life stresses that they have in order to focus on their own care. And so those are all really important aspects of that concept. And then we get to access and continuity. Basically, when are you open? How are you open? Are you open just one-on-one in person? Do you have access to telehealth? Do your patients have access to the technology necessary for telehealth or telephonic medicine? Are you open at times which are more amenable to your patient needs and their work hours? Or all those kinds of analyses, but also looking at the continuity of care when you are handing off within your practice, and also empanelment. Do you have providers that are sort of over prescribed in terms of, or over subscribed, I guess is the right term, with patients and others that have room on their panel, and is that impacting patients' ability to get in and see to access care or to build those relationships between providers and patients, and all of that is a really important aspect. And you can see how all of these areas could be important pieces of data or pieces of experience that your patients are having with your operations and can impact quality improvement. Let's go on to the next slide very quickly. I have a little bit of bubbly water here. The other concepts that we focus on are care management and support, which really looks at those complex patients, patients with significant comorbidities, maybe having medical and behavioral health issues as well, and really trying to figure out, are they going to benefit from the enhanced services that care management can provide? And of course, very often those resources are limited, so you've got to figure out which of your patients are going to qualify for care management, which you're going to concentrate on, and make sure that they have that person-centered care plan development that can really help them understand what the challenges of their care is, but also care are, excuse me, but also what their expectations are and what their goals should be. And this is also an area where the idea of person-driven outcomes is becoming more popular. The idea of not just having clinical or functional goals, but things like, you know, the patient who has COPD would like to be able to play outside for an hour with their grandchildren. You know, those kinds of measurable but very person-specific goals as well. Care coordination is about when you're getting care out of the practice, and you can see where those are very key potential breakdown areas. So when you send out patients or their samples for lab and imaging results, making sure you're getting those answers to your clinical questions back. What happens when patients are referred to other providers, and in this case, we're talking more about other human providers, that is, other specialists, clinical providers, that sort of thing. Care transitions really refers more to hospital providers or institutional providers. But in all of these cases, do you have those kinds of relationships with the local community, what we call the medical neighborhood, that are really going to help you be able to understand and track what's going on with your patients, particularly those who are seeing a lot of different providers? That can be very challenging. And there are still, unfortunately, providers out there who are using things like HIPAA to argue that they shouldn't be sharing information, when in fact we all know that that is not, in fact, in the HIPAA regulations. You can share the whole medical record with someone else who is providing care, except for psychotherapy notes. And then, of course, our last concept is looking at doing real performance measurement and quality improvement. So what are you analyzing? What are you measuring? What are you collecting? And then what are you going to concentrate on? Which aspects of care are you trying to improve? Are they specific to your practice? Are they something that HRSA is concentrating on? We all know that happens a lot. And then are you going to set goals? And are those goals going to vary by practice? So you might set a health center-wide goal, but practices that are already at or above that goal may have their own internal goals that they're going to set to motivate them to get even better. And looking at, are you actually able to intervene and improving that practice performance, and then sharing your results with your patients, with your staff, with your community, if that's appropriate. So all of those areas, you can see how they can all feed into quality improvement. And what I want to talk about now is really looking at that quality improvement cycle. So if you can go to the next slide, and how you can use sort of these different concepts in your analysis and in your work in quality improvement. So let's go to the next slide, which really just shows your basic quality improvement cycle. We have at NCQA, for our own work, we've done Lean, we've done Six Sigma, we've done lots of different quality improvement analyses and formats and things like that. But we are not prescriptive of how you're going to do QI. We are looking for the basic QI cycle. You measure something, or you're remeasuring it if it's an ongoing activity, and you're trying to see if you've actually had improvement. You analyze those measures. Or reanalyzing if you are in the middle of a quality improvement effort and you want to see if things worked. You determine what the challenges, barriers are to achieving performance, where your opportunities for improvement are, and then you figure out where you're going to intervene, you take action, and then you remeasure. So going through that cycle and trying to improve each time, and asking those questions that I think are so key, because when you are doing that analysis, there are really two parts of it, right? There's the quantitative, the sort of what is going on with the numbers, how are they moving in this pandemic environment we've all been working in. I know a lot of centers, the goal is not so much to improve in quality improvement, but to maintain current levels, and then hopefully improve as the pandemic lightens a bit. But the other aspect of that question that is so important is, why is performance moving the way it is? What is unique, different, special, challenging about your patient population? Is it about your the resources available in your area, the provider types you have access to, resource constraints in your own practices? All of those kinds of things are really important questions. And I'll give an anecdote that I love to give. It's one I've given before, so if you've heard me speak, I only have so many anecdotes. I apologize. But this was actually from my health plan work, which I started at NCQA back in '97 when I still had black hair, actually. And it was a health plan that had wanted to improve mammography rates, and they realized that they had a very similar patient population and had similar networks to their competitors that had higher mammography rates as reported through HEDIS. So they realized one thing they weren't doing that all the other health plans were is they weren't sending out birthday card reminders. So which we, as those of us who hit certain ages, it's always fun to get those birthday card reminders that say you're old now, so you need to get these tests to make sure you don't have these various ailments. And that's something that they decided to implement. And they spent a lot of money. I think it was like $1 million in implementing, designing and implementing this birthday card reminder, and immediately began to get fairly vehement complaints from women who were getting the birthday card reminder because they hadn't really bothered to do that why analysis correctly. And what the real problem was, they had one mammogram provider in their whole network. And it was the one aspect of their network that was different from their other competitors, and women just couldn't get in to get an appointment. And there were women who were waiting 6 and 8 months to get a mammogram, getting a reminder. Well, the last thing you need is a reminder when you've tried to do something and you couldn't do it. So the health plan did not succeed in improving their mammogram results. They did succeed in reducing their satisfaction survey scores, which is always fun, right? Because we know how hard those are to get back up. But when they did that, when they did the correct analysis and actually looked at the question that they needed to ask is, what are our patients complaining about? And in this case, if they'd looked at their complaints, they would have seen the number one complaint of women over 50 was that they couldn't get in to get their mammograms. And when they expanded their network, their mammogram rates went up, their satisfaction scores went up, but it was because they asked that why question. What they had done wrong was they jumped into what we call the ready, fire, aim problem, right? You think you know the fix you need to put in, you're convinced you know the problem, and so you just go to fix it without really doing that analysis as to why what's happening is happening in your practice. And then the other aspect that is really important is when you're looking at interventions, then how can you make changes? I've done programs and speeches out in the Intermountain West, for instance, and I remember talking about things like electronic prescribing and the old meaningful use requirement that you have somebody, at least one pharmacy that you can send an electronic prescription to, as long as there's one that can accept an electronic prescription within 10 miles of your practice. And one of the women in one of my audiences in Montana was like, 10 miles is my driveway. It takes me 20 minutes to get from my house to the first city road. That doesn't make sense given the size of the Intermountain West. So there may be things you can't fix, right? You can't change the transportation system. You can't change how distant someone lives from your practice. Those are things you can't fix, but what can you fix? And then how are you going to? Are there resources you can deploy, differently? That sort of thing, to be able to take those operational improvements. So in the next slide, if you can go there, I want to talk a little bit about how those concept areas then factor into these why questions. So when you're asking why are our numbers the way they are, well, one of the things you might want to look at is, are the patients that have diabetes, for instance, that we're looking at in our diabetes care measures, are they commonly having other issues which may prevent them from focusing on and managing their diabetes? So are there other behavioral health concerns? Are there other medical issues? Those kinds of things. If you are dealing with a desire to get patients, for instance, to lose weight or to improve their exercise profiles, do they live in an area that is a high crime area, so they can't just go out and take a walk, which a lot of folks would be able to do normally just to get exercise? Are there actually grocery stores with healthy food around? I know there's a huge battle going on in Washington, D.C., where I live right now, where we have 2 wards that do not have a full-time grocery store. So that is a food desert in the middle of the nation's capital, and it's Ward 7 and 8 on the other side of the Anacostia River from the rest of the city. And there was supposed to be a full-service grocery store already there, and the mayor is now taking steps to basically sort of force one into the wards because it's so vital. But if you're dealing with patients in those wards, then how are you going to help them access the healthier food you might need, or that they might need to be able to manage whatever conditions they're trying to. So those kinds of things. And as I mentioned, local infrastructure resources, are there other ways you can use that, particularly things like community resources that you might be able to put your patients in touch with to be able to deal with some of those life challenges so they can focus on their health care. When you're thinking about team-based care, well, again, what are the resources that you have, and can you deploy those differently? Do you have skills? Do you have MAs that have really good communication skills where you might want to utilize them for a lot more of those messaging back to patients, right? Sometimes the patient-provider relationship can be more of a power dynamic that makes patients feel intimidated and they don't ask questions, whereas having that same conversation through a medical assistant who's just very good at relating to people may be a way to at least gather the patient's questions and get feedback to them, but also to reinforce some of those messages in a more peer-to-peer, low-key kind of way. So that's something that may come out of a team-based care look, and of course, getting patient feedback about that. With care management, sort of what has worked or failed in the past, and are there things you can do to improve what worked and remove what failed? And then also, are you really choosing the right populations? If you look at different ways of stratifying your population, are you going to find different populations that you might want to focus on? And then that continuity, are you in a medical neighborhood where your other providers are good partners? Do you have the technology, things like HIEs and RIOs that have come in but may not be working as well as they should? We all have, know about the interoperability issues or data sharing issues with EHRs. Is that something that's going to impact your area? And then are there ways to get around that? To go old-fashioned methods of dictation or faxing or things like that if you need to be able to share information. If you go to the next slide. Um, and then we get into sort of the how questions. Okay, so if you know what the challenges are, then what are you going to do to help overcome them? So the food desert I mentioned in DC, one of the health centers was able to get a program. I think it was funded outside of their normal medical care, where they were able to get basically coupons to their patients to be able to go to some of the farmers markets in DC and get free fresh fruits and vegetables there, rather than relying on convenience stores and delis and things like that. So what resources are available? Are they useful, and are they improvable? Can you rethink how you're deploying your resources? You really should probably be looking at how your office-based care is being provided on an annual basis to see if there are ways you can be more efficient, but also, again, are there ways to have interactions with patients that reinforce messages or are able to sort of pull more information out from them if you're trying to figure out why they may be having specific challenges or specific concerns. Are there untapped skills, abilities, talent, that sort of thing? My sister is married into a Puerto Rican family, and her sister-in-law is a nurse and has become something of a nutritional expert in her. She works in a kidney transplant area of a hospital to help some of the Puerto Rican patients be able to make some of the traditional dishes in a healthier way. And she has no training in this; she's just a good cook. So that's something that the hospital has been able to access those kinds of resources. Are you able to meet your patients' expectations as to when you're seeing them and how you're seeing them? And so to think about that, we've seen a huge impact from telehealth, both good and bad, and there may be ways that you can really deploy that for patients that have access to the technology that's going to reduce no-show rates and improve that patient management. And of course, in continuity, are there ways that you can improve follow-up? And maybe that's a system-wide or a community-wide effort to get everyone communicating better and using better systems, or is it a one-on-one kind of thing with certain providers that you have to do? Are you educating your patients to make sure that they know that primary care is the center of the network and they're referring back, that kind of thing? And also, are there technology options that you can rethink? All of those are just some ideas of ways you can look at those why and how questions to figure out what you're going to do and to improve the care and service you provide. So I think that's my last slide.
Thank you, Bill.
All right.
Wonderful. So we have the slide that says Q&A. We're going to hold those questions just a moment. We do have a number coming in. We'll return to them at the end, but we'll transition to our next team, who is from the Joint Commission, and we're joined today by Pearl Darling. Pearl is the Executive Director for Ambulatory Care Accreditation Programs at the Joint Commission, where she directs business development, strategic direction, and overall project management for ambulatory care services, a program that covers over 2,100 accredited ambulatory organizations across 8,900 sites nationwide. Ms. Darling has been with the Joint Commission for over 17 years and has been instrumental in the growth of the large ambulatory care accreditation programs. In addition to her bachelor's and MBA degrees, she also holds a certified Green Belt in Lean and Six Sigma as part of the Joint Commission's Robust Process Improvement Corporate Initiative. Joining Pearl today is Royce Webb. Joyce is Project Director in the Division of Healthcare Quality Evaluation at the Joint Commission, where she is responsible for the development of ambulatory healthcare accreditation standards, survey methods, and survey education. She is a survey for the Ambulatory Healthcare Accreditation Program and serves on the Joint Commission's Radiation Safety Steering Committee. Ms. Webb is a registered nurse and holds an MBA and a board-certified medical practice executive with the American College of Medical Practice Executives. And so with that, I'll turn it over to Pearl and Joyce.
Great. Thanks, Cheryl, and thanks to the NAC leadership and team for having Joyce and myself here and being part of the conversation. And see how time flies, Cheryl. I'm actually been with the Joint Commission over 20 years now. I'm actually reporting out about 30 miles west of Chicago and enjoying summer, and really happy to be here with all of you. So next slide, please. So for today, we thought we'd provide just a high-level overview on our accreditation and PCMH certification process to show you how it aligns with your quality management initiatives. And then Joyce is going to share and describe the quality improvement strategies and tools that support problem solving and operational enhancements, as well as identify key steps for conducting a proactive risk assessment. Next slide, please. So in the beginning of our presentations, we always want to share our mission and vision to ensure how it aligns with everything that all of you are doing today. Our vision is that all people always experience the safest, highest quality, best value healthcare across all settings. And our mission is to continuously improve healthcare for the public in collaboration with other stakeholders like NAC and all of you by evaluating healthcare organizations and inspiring them to excel in providing safe and effective care of the highest quality and value. Next slide, please. We thought it was important to share with you the Joint Commission levers and how we improve care. And so certainly it is a collaborative relationship that we have with our accredited organizations as well as our key stakeholders. From accreditation activities via our standards and on-site survey process, to the support that organizations have with our standards interpretation group, or we endearly call SIG, and to all the FAQs that we post. For those questions that come in, prevalently, we post those FAQs to our website. For risk reduction, we rely upon our accredited organizations to report sentinel events to us. It is a voluntary process, and so you can imagine that it only really represents 2% of all the patient safety concerns across the US. And so what we do is we collect this information. We do put out sentinel event alerts. We put out any type of other complaint analysis. So we have all of this data that we house internally, and we are happy to share it with our public to just kind of share with all the hot topics and issues that organizations are being challenged today. And through Joint Commission resources, this is the arm of the Joint Commission that really supports these federally qualified health organizations that come to the Joint Commission for survey, for technical advisory services. And this is the arm that publishes our books and manuals. They host webinars and on-site conferences. And they also have center improvement projects, such as organizations that might be interested in high reliability or Lean Six Sigma. And then certainly communication. We are a source for solutions, and we put out lots of communication. And so certainly for all of you who may not be familiar, you can sign up for alerts to receive all the information across all our healthcare segments that we accredit. We also have performance measurement tools. We launched a huge Power of Data initiative a couple of years ago, And so now we have all of these data analytic tools that support organizations in their quality journey to help leaders really make those important decisions for clinical and business processes. And then many of you may know, we do have a satellite office in DC, and certainly we have leaders and folks there that support the Joint Commission at a federal level, and certainly work directly with CMS as well as HRSA. And then certainly we collaborate with agencies and organizations just like NAC to ensure that we are relevant in everything we do with our standards and survey process. Next slide, please. So all of you believe that PCMH certification has benefits, and studies have shown that medical homes decrease healthcare costs while improving patient care and access. And studies provide this advocacy and empowers patients to actively engage in their healthcare journey. And from this, it does allow patients to have access to their primary care clinician, as well as a team that supports their physicians and nurse practitioners or MAs or PAs. Their care is tracked and coordinated, more importantly, and certainly use of technology to support their care is important. And certainly this aligns with the Joint Commission, and so we launched our certification program back in 2011. And through Joyce's work in the Division of Healthcare Quality Evaluation, we're looking at those standards to continue to ensure that it is relevant today. Next slide, please. So again, just a high level, our certification program is based on the ARC's definition of a medical home. It is voluntary, it is optional, but it does require Joint Commission ambulatory care accreditation. We embed the PCMH certification. And so the beauty of our program is that organizations can have a survey as well as a PCMH certification concurrently. And the timing of the survey can take place either when they apply or certainly at their subsequent survey. There's no separate application. There's no pre-submission or upload of any documents or data. And it is a accreditation and certification for 3 years. Next slide, please. So just a high-level overview on the process. The survey complement, and the terminology is really how we assign surveyors to a specific organization's survey and PCMH certification. It may include 2 surveyors. It could be across 2 to 3 days, and it's based on the size. It could be more, based on the number of sites, patient volume, proximity of the sites, and probably at least 50% of those sites will be visited on site. And we conduct our surveys through tracers via patient tracers, which really traces a patient from the time they enter a facility through observations and interviews with patients and staff from the time that they leave the facility. And we also conduct system tracers, and those are tracers at a systematic overview of an organization. It'll take a look at infection control, data management, and environment of care. And then certainly, again, on the right-hand side, for those organizations who pursue PCMH survey with us, they just have to identify one location and then implement it across for their subsequent survey. Next slide, please. And so I wanted to just share this slide that kind of speaks to the synergy between the Bureau of Primary Healthcare and with the Joint Commission's ambulatory standards. There's lots of focus around clinical staffing, continuity of care, all the way to board authority for the Bureau side. And then on the Joint Commission side of things, again, similar synergies. We look at human resource, provision of care, performance improvement, as well as leadership standards. And next slide, please. So with that, I am gonna punt it over to my colleague Joyce, who's gonna talk about the quality improvement strategies as well as identifying key steps.
Thank you, Pearl. So appreciate your attendance here, this opportunity to talk with you. What I want to leave you with is really some strategies and tools to support you in your efforts to either implement or maintain your primary care medical home certification. And with that, I want to begin with some key principles that relate to performance and quality improvement. This directly relates to the Joint Commission's primary care medical home certification, because we have 5 operational characteristics that certification program is built around: patient-centeredness, the provision of coordinated care, comprehensive care, a real focus on quality and safety, and superb access. So keep those in mind as we move through these performance and quality improvement strategies. Some key principles, first of all: important to collect the data, figure out what the problem is. What is actually not working? When you're looking to improve your performance, really focusing on what are the areas that are challenged at this particular point. You not only collect the data, but take a look at it, take time to analyze it, and really understand what are some of the underlying root causes. Is there a gap in terms of resources that you need, or processes or policies in place? What other are related factors? And I'll touch upon this a little bit more about how you get at analyzing that data. But once you analyze the data and get to those root causes, it's really important to prioritize them. You can't do everything. You're stretched. You guys are working very hard. And so you really want to prioritize what are the major root causes that you want to attack. Now that you've identified what root causes are and these related factors, then you start to think about what solutions, how are we going to fix this? What are we going to do? And again, as you start thinking about what you're going to do to improve your performance, to improve the quality of care that you're providing and the quality of services that you're providing, you need to also prioritize. Again, you can't do everything, but which solutions will have the biggest impact? And then once you've implemented solutions, you want to take time to go back and monitor throughout, actually not even go back, but throughout the process of implementing solutions, you want to monitor progress. You want to check and see how's it going and what changes, what adjustments might be needed. Next slide. So some tools that I'm going to just give you a brief introduction to: brainstorming, the use of a fishbone diagram, flow charting. These are some tools that are commonly used when you're looking at performance improvement. And so we'll go right into the next slide. First strategy is brainstorming. At a minimum, you will come away from this presentation with a few tools and strategies. So brainstorming is really the use of collective brain power to generate as many ideas as you can in a short period of time. You can't just sit and think about a problem, think about an issue. You have a limited period of time. You bring the right people to the table and start thinking, what is not working? But then even more importantly, what is, why not? Why is this not happening? It could be no-shows. It could be long patient wait times. And wait times are more than just sitting in the exam room. Wait times could be on the telephone as well. Or wait time could be the amount of time to get an appointment. This is information that you can glean and will glean. I mean, you already do it from your voice of the customer, your patient satisfaction surveys. So there's something not working. You want to ask that question, why not? And then as these topics and problems and issues are identified, then you want to make sure that as you're brainstorming and those issues and topics are shared, those ideas, take the time to make sure that they're clearly articulated in terms of there's an understanding of what the issue is. Sometimes in brainstorming, there's a broad statement, a very general statement that comes out, but you want to take the time to get to the detail and truly understand what is that individual saying that's not quite working, and why not? The focus is really on getting as many ideas out there as possible. They don't have to be perfect. They certainly don't have to be articulated or worded in the most perfect way. It's just getting those ideas out to figure out what's not working and why is it not working. During brainstorming, no criticism. It's all ideas are welcome. You hear when you're doing a brainstorming session, you hear feedback that you may not like, you may not agree with, but it's important that all of your teammates, the ones that you brought to that table to participate in brainstorming, have the opportunity and are comfortable sharing their perspectives. Next slide. Another tool is to really, the fishbone diagram really gets at cause and effect. This provides a visual of the problem, and I'll give you a visual on another slide, on the next slide, but it really starts to get at what are some of those underlying contributing factors. When you look at this visual, when you put it out and plot out a particular problem and related factors on this fishbone diagram, it helps you to understand why a problem or an incident occurred. It helps you really look at what are some of those underlying and related possible causes and factors, and it starts to reveal cause and effect relationships. This fishbowl diagram can be as detailed as you like. You might find that depending on what process that you're looking at or what problem or challenge that you're evaluating, it can just be a very simple diagram. Next slide. This is an example of a fishbone diagram. So you see here, there's at the head of the fish, so to speak, and the head of the diagram is the problem. Those three circles where you under the word effect. Wait times, for example, could be the problem. Could be low patient satisfaction scores. It could be no-shows, which can really, cause waste to your system. You've got providers and staff there ready to roll, but then you've got appointments that are left unused. Those are examples of what the problem might be, and that's at the head of the fish. And then you go back to the bones of the fish, where you're getting to what are those major causes. So you'll see they could be because there's something with the equipment, perhaps not functioning, not enough equipment, could just be process, might be policies, could be the people. Maybe you don't have enough people, or the people that you have, perhaps they need further education. Could be materials, environment. It could be management in terms of providing the guidance, developing those policies and procedures, doing the monitoring that's necessary to really support quality improvement. Next slide. Again, just giving you an overview of some of these performance improvement strategies and tools, but I want to leave you with these: process map, flow chart, taking the time to actually work with your team to map out all of the process steps from start to finish. Let's say, for example, you're talking about wait time on the phone. Plot that out. Patient calls. What happens? Then what happens? You might find that this is very helpful because it allows you to visualize the process flow. It shows you all of those inputs and outputs, links to other processes. How many times does the patient have to be transferred? Is there waste and redundancy in that process? Bottom line is, we all know and have heard this, a picture is worth 1,000 words. When you're process mapping and plotting out a flow chart, I'm a certified change agent as well as a green belt for change management. And when I've done this, we have been able to really determine that as we work as a team to just plot out what the process is, you can find really amazingly that you didn't even know that the left hand didn't even know what the right hand was doing, that there was a redundancy or waste that you didn't even know was included in the process. Next slide. So that can be a very helpful tool. You also want to look at your processes from a systemic perspective. What you see, the symptoms, that is just what's showing, what's above the surface. And when we talk about root cause analysis, really getting to the root, what are the underlying causes? You don't want to just stop with fixing fixing the symptom, putting a Band-Aid on it, but really taking the time to engage in brainstorming, process mapping, plotting out the process and related causes so you can really get below the surface. This is not always obvious, and when we talk about root cause analysis, keep in mind that there can be many root causes. Next slide. Here's a visual on this slide of a process map or a flow chart, and I talked about mapping a process out. And so there's specific shapes that you use. You'll see here, this is just an example of getting up in the morning. So the start in that blue circle there, you start, first thing, an alarm rings, for example, and then you've got a decision to make. Do you, first of all, before the alarm rings, you've got a relay set there. Do you set it for, 5 minutes? Yes, you're ready to get up. That's the diamond there indicates there's a decision point. Are you ready to get up? No, not quite ready to get up. So you hit the snooze button. It goes back into a relay. The next step, alarm rings again. You have to make that decision again. Are you ready to get up? If yes, then it goes to the next step. You get out of bed. And then that's the end. This is a very short process, but it gives you an idea of activities, of start, finish, the direction of the flow of that process, the decision that needs to be made. And all of these arrows and lines are actually connectors. A very simplistic example of a process flowchart, but it's something that we do every morning. Alrighty, so next slide. Keep in mind as you work on challenges, as you work on performance improvement or quality improvement, there are challenges and barriers that you need to be aware of. We have a tendency to jump to conclusions when folks come to the table and start thinking about a problem, or even before they come to the table, there's something that's really been bothering them about something not working appropriately, but they've already got it in their mind exactly why that thing is not working. And oftentimes, plotting out the process steps using a process map can start to reveal exactly what is the problem and what are the actual contributing factors. Another barrier or challenge is identifying solutions right at the beginning. Many times we think we know what the solution is, but first of all, you really need to spend time understanding what the root causes are, what are those contributing factors, that those are clearly identified. It could be that when you think about patient-centeredness, for example, and you have no-shows, a related factor might be appointment availability, might be your scheduling processes. It might be your reminders. Are patients getting reminded or not? For wait times on the phone, it might be, then you might have a need to really think about and look at your peak times when most of the calls are coming in, and does your staffing correlate with that? So there's multiple challenges and barriers there. You want to make sure your solutions that you come to are a priority. Then you want to follow up, and then you want to monitor to make sure that whatever you put in place, that indeed that is happening the way you anticipated. Next slide.
Thank you, Joyce. We have about 1 more minute to wrap it up. Thank you.
Okay, thank you. So here on this slide, you see the Joint Commission's proactive risk assessment. There are 8 steps. For more detail, you certainly can go to our manual, the leadership chapter, intro, and it really covers so much of what I've already shared, about looking at your processes, test them out, monitor for effectiveness. This is the final slide. Next slide. Final tips. You'll get a copy of these slides. You want to make sure you've got senior leadership buy-in, appropriate resource allocation, manage your time, write down what you've talked about, clarify responsibilities. You want to walk through a Gemba walk, is actually walking through the actual work processes. And then you want to monitor any solutions that have been implemented, take time to check compliance and then make adjustments. But then once you make adjustments, then you need to monitor those adjustments. With that, I'll conclude and I will hand it back over to Cheryl. Thank you.
Great. Thank you, Pearl and Joyce. Wonderful. And again, to both our organizations and panelists today. We're going to jump right in. We have a number of questions that have come in. So I think we'll try to move through these fairly quickly. We're going to go first to Bill and NCQA. And the question that came in the chat box was whether NCQA is considering paralleling its criteria with HRSA's site visit protocol. And if yes, would there be consideration of auto credit?
Yeah, I think the answer to that is that our criteria are set obviously for all practices, so they wouldn't specifically align with the site visit criteria. But we have had discussions with HRSA both about sort of giving folks that have the PCMH credential some alleviation on the HRSA side in terms of what they're looking at, and vice versa. So, if you've met certain HRSA requirements, would that be evidence for NCQA? We haven't moved as far as we'd like on that, but it's definitely something that we're in discussions about. And in fact, I will bring it back up on our next discussion with HRSA. But yes, we would like to reduce burden as much as possible, but right now we don't have any specific plans.
Great. Okay. Thank you. For Pearl, you mentioned in your discussion some of the quality analytics tools, Quality Portal, Quality Check, Accelerate PI. Could you just speak very briefly, elaborate a bit on those?
Yeah, so like I mentioned a few years ago, the Joint Commission embarked on a strategic initiative called the Power of Data. And so what we do offer organizations today, typically done at the exit of a survey, is put together a safer matrix, or what we call a safer dashboard. This allows organizations to make rapid decisions on how to prioritize some of their patient safety concerns, especially during after a survey. So that's one tool. The other tool is what we call a dashboard. For those organizations more on a deeming side of things, we provide a dashboard which, again, utilized during survey, focuses the conversation to support the organization's quality improvement initiatives. So these are just a couple of the tools we've done around data, and certainly lots more opportunities to create and develop more tools to support organizations on their quality improvement journey.
Great, thank you. Going back to Bill a moment, the question was that the PCMH, NCQA's PCMH recognition standards focus on care management and support, and then the individual knows that there's an NCQA case management program. Could you speak a little bit about any relation or connection between those?
I actually can't, but I can certainly follow up. I'm not familiar with our case management program itself, but I believe that is actually a program for organizations that do case management sort of on behalf of health plans. So on our health plan side of things, we have a lot of sort of subsidiary programs that allow what we call health plan delegates to get their own certification so that the health plan doesn't have to do as much oversight. We haven't done that on the PCMH side. So you certainly, if you're looking for an outside vendor to do case management or care management, you can certainly look at those vendors, but it is not specifically something that we have integrated into the PCMH program.
Great, thank you. One more, I think, quick question, and then we're going to switch back to Joint Commission. So the question was, can a clinically integrated network seek PCMH certification as a group, or would it be only for the individual health centers?
So the recognition credential itself is for the individual practice sites within a health center. So it may be a little bit even more granular. And we normally do look at the health center as one organization in itself, and they're allowed to share evidence across all of their practice sites, things like that. We haven't had a sort of a group of centers try to come in together, but certainly that is something that it sounds like it's large enough that we could work with an organization to facilitate that process. We would still have to go through our existing systems, but we could assign the same teams, et cetera, so they're familiar with the network to make that process faster and more efficient.
Perfect, thank you. This next question is actually to both organizations. We're going to start with the Joint Commission. And the question is, with regard to your PCMH recognition or certification programs, so depending on your organization, what areas do you see health centers most struggle with in terms of meeting standards or requirements? And then what solutions do you recommend? So maybe just a minute or two response. So we'll start on the Joint Commission side.
Pearl, I'll start. When we regularly look at our most challenging standards, the standards that we find our PCMH certified organizations struggle with, and we found that those requirements that they struggle with most are ones that really require a change in process, in the way the clinicians interact with patients, documenting that, where that documentation is actually placed and located, because not all EHRs have fields that really align with primary care medical home. And examples would be establishing self-management goals, working with patients in partnership to establish those goals, and then deciding where you're going to document that so that on subsequent visits, subsequent clinicians can pick up on which goals are we working on and what is the patient's progress to those goals. And I'd say another area would be assessment of health literacy. Taking that assessment, conducting it, documenting the results of that assessment. So again, and documenting it in a place so that on subsequent visits, all of your clinicians and folks who interact with that patient are aware of that. These are two areas where it really requires quite a bit of a significant transformation for some organizations in terms of putting new processes in place to capture information as well as document it. But it's just really key to providing good quality care as a primary care medical home.
Thank you. And Bill, for NCQA, areas that you see that health centers struggle with and any solutions you can offer?
I think the biggest area is really in that continuity and coordination with other providers. So having that network or sort of that neighborhood approach of being able to interact and get reports back, and there isn't a great easy solution to that, right? The fix there is to use your systems as best as possible, but also to build those relationships, typically outside of specific patient cases, to try and improve that communication back and forth. So I think that's an area that there can be a lot of frustration depending on the location you're in, and how cooperative and collaborative the other providers are. But I think that's also an area where if you can invest the time to build those relationships, you can get a lot of benefit out of it.
Terrific. Okay. Final question, I think, before we have just a couple closing items to share with everyone. And that is, and again, I'll go back to the Joint Commission team first. This is for both organizations. As health centers are considering strategies for moving forward and looking at different ways of working and innovation, where do you see the role of innovation in your PCMH model? So just a brief response. We realize you could go on with this, but the role of innovation in your organization's PCMH model.
Well, I'll begin, and Puri certainly could jump in. One area for sure is something that we've come across over these past couple of years is really how to best integrate telehealth, the use of telehealth and the remote provision of remote care. Since we've been doing it, it's going to be really important to figure out how that can be used as an adjunct to in-person care.
I would just like to reiterate that Joyce actually was on a panel today around telehealth and strategies so the Joint Commission can support primary care providers and other settings across the continuum of care. So that is certainly a good topic that we definitely want to make sure. Digital health is certainly big, as well as telehealth.
Bill, and you at NCQA?
I think one of the things we always try to do is really promote innovation wherever we can. So we don't have a lot of strictures on how to do things, but I think just like the Joint Commission, the biggest change is really telehealth and how to integrate that. It has been an area of a lot of interest for years. The pandemic made it suddenly a requirement. And so I think probably the next area of innovation there is going to be figuring out when telehealth is most appropriate and when you really, other than if you have to physically take a sample, but also from the patient, obviously they have to be in person, but also where is it really appropriate for management and where is it beneficial? Where is it going to get your sort of maximum benefit for helping patients manage their own care? And I think that's really where telehealth is going to come next.
Excellent points. Great. Well, on behalf of NAC and all of those on the line, we'd like to thank both the NCQA and the Joint Commission for your time and your expertise today. There may be a few questions that are very organization specific. If that's the case, we will follow up with you individually after this call and we can respond to individuals. As you saw, the slides will be posted online. I'd like to, coming up on your screen, or just contact information as well. So feel free to reach out to any of the contacts you see on the line. And then 2 or 3 slides we'll just share real quick in our last minute. First is an announcement about some session coming up. And then our final slide, I think we have 2 more. Again, I think many of you are participating in our Elevate Learning Forum. Feel free to reach out. You will get the slides and link later. And then finally, we close right at the top of the hour, just reminding you that we do have a Care Team Digest with more information. And most of all, just to thank you. We know you're busy and we appreciate all you do. And thank you for joining us in this important hour and important conversation. Thank you to our speakers. And thank you all for joining us today. Bye-bye.
Bye, everyone.
Bye.